Yeah, it's Jeff Hawkins, and I'm the president and CEO of Truvian Sciences.
Great. So we're here today because tomorrow morning, FDA is going to announce an emergency use authorization for Truvian's COVID-19 antibody test. And so if we could start out, could you tell us a little bit about the antibody test and how it works?
Sure. Yeah, so our antibody test is actually a very simple, very fast test to look to see if your body has had an immune response to a prior COVID-19 infection. So a small sample of blood is added to a little cassette. 1 drop of buffer is added through a little dropper bottle that looks sort of like an eyedropper bottle. And 10 minutes later, you look at the cassette and can see if you have M antibodies, G antibodies, or if you have both. And then there's also a line for a control to make sure if you are negative for antibodies, you know that that test still worked.
Okay. And if you could explain a little bit to us about what the accuracy measurements that are listed mean and what they might mean to both a doctor and also to a patient, to a layperson.
Yeah, so we use these words in diagnostics like sensitivity or specificity. The way to think about it is sensitivity is when the antibodies are there, how often do you detect them? And specificity is best to think about when the antibodies are there, how often do you only pick up the right ones? So when I do say you have something, did I pick up the right antibodies? I didn't pick up some other closely related sort of antibody to something else. So when you look at our data and we say we're 98.4% sensitive, it means when the antibodies for COVID-19 are there, greater than 98% of the time, we're going to detect those antibodies. And then when you look at our specificity, which is 98.9, so almost 99%, it means when we do tell you you have antibodies, there's a 1% chance, only a 1% chance that we detected something that wasn't related to COVID-19.
So that's a very high accuracy for a rapid turnaround test.
Yeah, it is. It is. I think the other data that we are working with a large academic medical center to publish compared this small sort of deployable test to a big lab-based analyzer and saw very high concordance, over 98% agreement between that large lab analyzer and this little test. So that sort of speaks to the accuracy of it despite the simplicity.
Okay. Who should have a COVID-19 antibody test?
Yeah, it's a great question, and there's sort of a range of use cases that have evolved over the past few months of the pandemic. In the really early days, the predominant use was actually blood banks trying to help identify people who had been sick and recovered and could therefore donate plasma for use in treating really ill people. And that's still going on. Blood banks across the country are offering antibody testing to find those folks who can donate because that convalescent plasma continues to be a key part of a treatment regimen that is out there. But more recently, you're seeing other utilization. So one of the most common ones now is you're hearing all this about asymptomatic spreaders or mild disease. And one of the challenges there is if you don't have symptoms, you probably didn't go and get tested. Or if you had a very mild case, since the symptoms of COVID-19 look so similar to other respiratory infections, you may not have even sought out any testing for COVID-2, the actual coronavirus, which means we might be way understating the number of people who are infected. So you're seeing public health, you're seeing the CDC, you're seeing large academic medical centers do these broad what are called sort of seroprevalence studies, basically try to understand the actual rate of infection. And I think the CDC most recently put out data in sort of some of the big hotspots around the country. And it says the positivity rate may actually have been as much as 10-fold higher than what's reported when you look for people with these antibodies. And then I think as we move into businesses trying to reopen, you have frontline healthcare workers, you have workers in skilled nursing facilities, maybe in very high density areas where you can't get social distancing. So think of like some of the outbreaks we've seen in food processing and manufacturing in some of these areas. I think you're starting to see antibody testing as a complement to, the swabs and PCR to really try to plan out how they how they manage those facilities, how many people they put in those facilities, weigh what is the positivity you're seeing in that facility versus in the general community. So therefore, is it equivalent, or is it, getting worse in those higher risk facilities? So we're starting to see it be a complement in that space, as well as we think about just how to manage the new state of business, where you just can't simply do what we're doing and be at home, or perhaps just spread out and socially distance, which is obviously a great measure.
And speaking to that, the intuitive idea would be that if you tested positive for the antibodies, you would have some measure of protection against COVID, um, at least for some time.
Mhm.
Do we know anything about how long the protection might last, or how good the protection is?
Yeah, so this is the challenge in science, especially immunology, is the way we get so confident on it in other areas is time. But what we do know, so there are a lot of studies that have been reported. There are a lot of reports that are going to turn into peer review. So I think one of the challenges is just the data is coming out even faster than it can go through the typical channels. But what we're seeing is that certainly people who are hospitalized are some of the first ones that were tested for antibodies. When you look at those folks, we have data on patients serially tested over the course of 3 months, and most of those people still have antibodies, right? When you look, there's a recent study out of UCLA that even looked at people who had more mild cases, and they found that 2.5 months later, people still had antibodies. But not everybody develops an antibody response. There's sort of a long host of reasons. As an example, somebody we tested in our trial was immunocompromised and was on immunosuppressive therapies. They didn't have an antibody response. Now they recovered and were able to leave the hospital, but sort of intuitively, we wouldn't have expected them to have a response, and they didn't. So right now, the data says the vast majority of people who recover do have a response, and that it's still there. But the uncertainty is, how long does it last? And then the other part of your question, Mary, is really, and what level of protection do you get? So right now, we're not hearing widespread reports about people getting reinfected. So it sort of implies that if you have antibodies, you have some sort of protection. We're not seeing people sort of with 2 and 3 sort of courses of the disease. But I think both of these questions can only be answered sort of over time, as we monitor and see how long do these antibodies remain. They'll come down, but how long do they remain? And then how protective is it? Do you ever get reinfected a year from now, 2 years from now? We don't know the answers to these, and really only time and monitoring is the way to answer that in sort of a scientific way.
Mhm. You mentioned like the example of sort of say the meat processing plants and things like that. Are there other obvious institutional or employment type users who are obvious candidates for maybe testing their whole employee base, or based on what we've seen this week, athletic teams, or college campuses, things like that? Are those some obvious users, or have you heard reach outs from those kind of groups?
Oh, so we've been fortunate to actually speak to a few of the professional sports teams, and we do understand that they are using both antibody testing and PCR. They have sort of a combined testing approach that they're using with sort of the athletes and people closely related to the athletes. So training staff, people who just can't possibly social distance. So it's a part of their strategy. I think manufacturing environments, I use meat processing simply because there's a lot of headlines around sort of some of the outbreaks we've seen. We've seen something similar actually in reports, in agricultural areas, again, where people are out working, even though they're working in fields, they're fairly high, proximity to each other, or have other sort of risk factors. So I think manufacturing in a bigger picture is probably applicable. You think about an assembly line, you think about a manufacturing facility, they're not designed to have big spacious offices and
Mhm.
like desk room. I mean, we're talking about people working even at the lab, at a bench in a lab. I think the other area too, obviously frontline healthcare workers. We're fortunate, I think, as a country, we're not hearing about even more illness amongst frontline healthcare workers. You think about the risk those folks are taking every day treating, an ability to just monitor those folks over time, to to understand if people are actually getting it and are have more mild cases. I mean, I think that's another area we'll likely see it. So yeah, sort of sports, manufacturing environments, frontline healthcare. I think universities will have to answer that question of how do they do it um, over time, especially maybe not just for classroom, but if you think about opening the dorms, I think way back to to college and grad school and being in dorms, I could imagine it would be very useful in that environment to understand if the, especially with the data saying younger people tend to have more asymptomatic cases, it could be a very effective way to help monitor that and potentially refer people out for PCR or balance the PCR testing when it's negative to have another measure of potential positivity rates.
So explain exactly what the emergency use authorization is
Mhm.
and how a person who thinks they might need a test can get access to it.
Sure. Yeah. So, the emergency use authorization is sort of a way the FDA sets forth a set of standards for products to get to market. But those standards and some of the, sort of requirements are reduced a bit from what they normally would be if you had to go through a formal, what would be called a 510K or a PMA. There's sort of these words that we use to describe different FDA processes. The emergency use is sort of a set of standards that are just meant for this. And longer term, the products will have to be converted to the full path. And we've seen this before in the US when we had 2009 H1N1, which many of us will remember, nowhere near this, but it was a big, sort of a big spread. There was an emergency use authorization process at that point. So it is a regulatory process over time. You do additional work to get sort of to retain that, because eventually the FDA will pull back the ability to have a emergency use authorization. And for people who want it, so this test, both, we're not the only antibody test provider. It's going to, just like with other areas in this pandemic, it's going to take a lot of companies to be successful. But these tests are going to be made available through, there will be employers that will offer it, routine, just healthcare, clinics, your primary care doctor, places like that. We're seeing public health facilities wanting to offer this type of testing, and even the drive-through clinics where a lot of people are getting swabbed and tested are beginning to offer these antibody tests as well. And then obviously the large medical centers in major, metropolitan areas have the ability to do this type of testing as well. So many of the normal places people would go to access healthcare, but we think with this simple test, we'll also start to see it in some of these sort of newer modalities that have popped up to support coronavirus, like these drive-through clinics and other things.
And will this test be covered by insurance?
Yeah, so far we're seeing that insurances are covering these antibody tests. They have been from the beginning. I think if there's anything that has been that's historically been a roadblock to new technologies, whether diagnostics or therapeutics and healthcare, often the process of getting those things reimbursed is a very long process. I think in this pandemic, the insurance companies, both private and public payers like Medicare, stepped up and right away started paying for testing. So we're seeing widespread coverage of both the PCR testing that people have been getting, but also the antibody testing. We've seen coverage in both.
Okay. And if a person tests positive and turns out that they have antibodies, should they still go ahead and get a vaccine in a year to 2 years when a vaccine is available?
I would certainly recommend people do. I will. I'm not antibody positive. I've tested myself in the development of the product, as you can imagine. But I think it goes back to my earlier feedback, which is we're fortunate that we're seeing people with antibodies here 2-3 months removed from their recovery. We're fortunate that we're not seeing big reports and studies coming out saying you can get reinfected. So all those things are sort of good signs that you're getting some level of protection and that the protection's not just going away overnight. But because we don't know how long it lasts, and because we don't know if it's true pure immunity, or if you could still get sick and get a lesser, I think people should still get vaccinated when the vaccines become available. I think the real question will be, might antibody testing play a role in how we think about the rollout of the vaccine? Because obviously somebody with antibodies, while we don't know if it's 100% protection, and we certainly don't know if it's a lifetime, it's too early. Perhaps those folks can be deferred to a little later, and we can get the initial vaccine doses out to high risk people who don't have that protection. I think it could end up playing a role in that, because it's hard to believe that despite great efforts in the vaccine world, we're not going to instantly have hundreds and hundreds of millions of people able to get vaccinated. It's going to take some time to do that. So it could end up playing a role in that. But whenever it becomes available to me, I can assure you I'll get the vaccine, independent of if I end up developing any antibodies from any exposure at any point.
Okay. Well, those are all my questions. Is there anything we haven't covered that you'd like to add?
I think the only thing I would add for you sort of reporting on this to consumers is where we have met a lot of people through this process who were sick in the February, January, March timeframe. The symptoms are so close to sort of COVID for general respiratory things, right? You get the upper respiratory problems, you get the shortness of breath, you get fevers. So we know a lot of people who think, hey, I had COVID, I'm protected. I can say I'm one of the people who thought, hey, there's a decent chance my whole house got sick in February, maybe there's a chance we had it. And I got tested, and as I said to you, I do not have antibodies to it. So I think you will see, as these tests become very available, and these rapid tests like what we've done, you can get this result in just 10 minutes. You're going to see a lot of consumers who are interested in understanding, maybe that thing I had back in January, was that COVID or was that something else? And I think you're going to see people seek this out to just understand what they may have had, and maybe plan for how they're going to take certain precautions, how they might think about making sure they get the vaccine, et cetera. So I think that'll be an interesting evolution as these tests become very accessible.